Vitamin B12 deficiency drives severe, irreversible neurological and hematological pathologies. Without sufficient B12 for red blood cell formation and DNA synthesis, structures break down. Recognizing the classic triad of symptoms, megaloblastic anemia, peripheral neuropathy, and cognitive decline, is straightforward in advanced cases. The challenge lies in the biochemical diagnosis, which is currently in a state of professional flux. The UK's National Institute for Health and Care Excellence sets the threshold for absolute B12 deficiency at a total serum concentration under 180 nanograms per liter. Herein lies the clinical paradox. National guidelines dictate strict numerical thresholds for treatment, yet the laboratory assays used to measure these exact thresholds are misaligned across different testing platforms. To manage B12 deficiency without misdiagnosing vulnerable patients, clinicians must move beyond total serum markers, integrate active B12 or Holotranscobalamin algorithms, and understand the precise metrological limits of their local laboratory assays. Relying on a standard laboratory printout without understanding the underlying assay context is a critical vulnerability in clinical decision-making. This flowchart from the NHS Norfolk and Waveney Integrated Care Board serves as a structural spine for diagnostic decision-making. The entry criteria mandate testing for megaloblastic anemia or clinical suspicion of deficiency, like fatigue, impaired gait, or cognitive difficulties. Instead of total serum B12, the protocol directs clinicians to check holotranscobalamin, the biologically active fraction, to improve accuracy. When holo-TC drops below 25, deficiency is likely, triggering reflex testing for intrinsic factor antibodies. However, intrinsic factor antibodies are present in only 50% of true autoimmune gastritis cases, necessitating alternative investigations. Conversely, if holo-TC exceeds 70 in an asymptomatic patient, deficiency is highly unlikely. The diagnostic friction occurs in the indeterminate zone, between 25 and 70. Here, the protocol advises an empirical trial of B12 treatment or close laboratory monitoring. By embedding qualitative clinical judgment directly into an indeterminate numerical zone, this algorithm formally acknowledges that biomarker testing has limits. To understand why that uncertainty exists, we have to look at assay commutability. This baseline represents the World Health Organization international standard. Currently, the Roche-Cobas assay serves as the calibrated baseline. External quality assessment data reveals severe variances. The Abbott analyzer overestimates total B12 by 7%, while the Beckman analyzer drifts further to 16%, and the Siemens analyzer overestimates by a massive 18%. The NICE guideline threshold of 180 nanograms per liter was derived by combining results from two different total B12 assays routinely used over 30 years ago. Those reagents and calibrations are obsolete. Methodologically robust studies utilizing current analyzers demonstrate that a more specific and accurate threshold for identifying absolute deficiency is actually 244 nanograms per liter. The immediate clinical risk is mathematical. A highly symptomatic patient could have a true B12 value sitting below the line of deficiency. But if their local hospital uses a Siemens analyzer, that 18% variance artificially inflates their reading above the 180 threshold. Applying strict numerical thresholds blindly across non-harmonized laboratory platforms actively denies treatment to patients who biochemically require it. Once a deficiency is confirmed, the clinical response is not monolithic. Treatment protocols are driven entirely by the identified etiology. This NHS treatment matrix maps underlying causes to appropriate clinical interventions. The first category addresses irreversible pathways caused by severe malabsorption, including autoimmune gastritis, total gastrectomy, and terminal ileal resection. Because absorption is permanently damaged, this pathway strictly requires lifelong intramuscular injections of hydroxycobalamin, administered every 2 to 3 months after an initial loading phase. Conversely, the matrix outlines modifiable pathways. These are deficiencies induced by long-term medication use, such as metformin, or by strict dietary restrictions. NHS guidance confirms that high-dose oral cyanocobalamin at 4 mg per day for 8 weeks is highly effective for non-autoimmune etiologies, challenging the assumption that all severe deficiencies require injections. A precise diagnosis dictates whether a patient requires lifelong invasive injections or can be completely resolved with a temporary high-dose oral therapeutic. Effective B12 deficiency management is a hybrid execution. It requires strict adherence to clinical pathways, paired with deep laboratory skepticism. Initiating an empirical trial of treatment for a symptomatic patient in the indeterminate Holo-TC zone is a mathematically sound decision that accounts for known assay variances. Until global quality assessment programs force universal adoption of the World Health Organization standard, clinicians must interpret local laboratory thresholds dynamically. The priority must remain on targeted etiological investigation and clear clinical signs, rather than absolute biomarker numbers. Achieving true diagnostic accuracy requires treating the complex clinical presentation sitting in front of you, rather than an uncalibrated number printed on a page.